Morning. This is a session of the Neurotology Eastern Region Virtual Education Series. And today we have Dr. Bryan Ward, Associate Professor at Johns Hopkins, who's going to be talking about management and diagnosis of eustachian tube dysfunction. Welcome, and thank you so much for joining us.
Oh, well, thank you so much for having me. Okay, good. I know I did a practice run of this, but I still couldn't find the share screen, so I got it now. All right, excellent. Is that working okay?
Looks good.
All right, awesome. Well, thank you, Mallory. Thank you, Eric, for inviting me to be a part of this fellow education program. So as you heard, I'm a neurotologist at Johns Hopkins. I spend much of my time researching and treating patients with peripheral vestibular disorders, but I have developed an interest in the eustachian tube. And I think for most of residency and really most of my fellowship as well, this structure was a little bit of a black box. And even today, I often hear of it as like, well, you've got ear fullness, it's probably eustachian tube dysfunction. So I want to kind of help make this a little bit more transparent by teaching you some of the lessons that I've learned. So this presentation reflects that of my partner at Johns Hopkins in the treatment of patients with eustachian tube disorders. This is Carrie Neiman, as well as that of my mentor, Dennis Poe. Carrie and I both briefly trained with Dennis up at Boston Children's Hospital and Massachusetts Eye and Ear Infirmary. And I want to thank Dennis for all of his mentorship and also for allowing me to use some of his slides for this presentation. So I have no financial disclosures relevant to the presentation, but I will be discussing some off-label use of eustachian tube devices. The objectives are to discuss the normal eustachian tube dysfunction, also understand obstructive and patulous eustachian tube dysfunction, as well as the role of nasopharyngoscopy. We're going to talk about new treatments for obstructive and patulous eustachian tube dysfunction, and much of what we're discussing here, what I'm discussing here, is shown is included in greater detail in a chapter in Cummings Otolaryngology in the new edition. So seek that out for additional info. I'm a big believer in the history of medicine and kind of understanding it and how it can help us better understand where we are today. So I love to intersperse historical vignettes throughout my talks. So you'll get several of those today. The first of which is Bartolomeo Eustachii. So Eustachii was an Italian anatomist from the 16th century, and he provided the first detailed description of the Eustachian tube. And yes, I guess we should be calling it the Eustachian tube, but I'll just call it the eustachian tube throughout the lecture. Eustachio did not mention the function of the tube, and if you're interested in seeing some of his original descriptions as well as drawings, they're available on this site here. So this is a cadaveric dissection that Dennis Poe had done, showing the anatomy of the eustachian tube when it's been kind of filleted open. And to orient you, we have the nasopharynx here, the middle ear here, and then this narrowing here is called the isthmus. And what you'll notice is that about 2/3 of the eustachian tube, or about 2.5 centimeters of it, is the cartilaginous portion here. And then there's this narrowing, and about another 1/3 of it is the bony eustachian tube. And so when we're thinking about the anatomy, it's helpful to think of kind of nearby structures. One thing that we seldom look for, even as fellows, is kind of what the eustachian tube looks like on a CT scan. So this is an axial CT scan with contrast. And what I want to point to is this protuberance here. This is the torus tubarius, and the eustachian tube is actually anterior to that. So it's kind of going in this direction here. If you go posterior to that, you get to the fossa of Rosenmuller. This is where the adenoids are, and often where some of that, potential that new salivary organ exists. And in some folks, they have these really deep fossa of Rosenmuller, all the way up to this area here, which is the carotid artery. So whenever you're thinking about the anatomy of the eustachian tube, you always have to think of kind of where is the carotid artery with respect to where you are. So on the right here is a rigid endoscopic view of the left eustachian tube. And this is what it looks like on cross-sectional histology. And so if you took a cross-section through this here, you would see that there is the cartilage of the torus tubarius, which is this. And it kind of forms this hook, like almost like a shepherd's crook shape to it. this cartilage is anchored to the skull base by these suspensory ligaments here, such that the whole thing, the whole structure can swing on the skull base. It's lined with a pseudostratified columnar epithelium. It has lymphoid follicles within this mucosal tissue here that go all the way up to the isthmus. And in this part here, which we call the anterolateral wall, there are a couple structures to know about. One is this fat pad of Ostman, which is just kind of a deposit of fat, and then the tensor veli palatini muscle, which is right here. So there's two big muscles, two important muscles to know about. One is the tensor veli palatini muscle, and the other is the levator veli palatini muscle. And we're going to talk about those in greater detail when we discuss function. So Antonio Valsalva is the next stop on our historical journey. So Valsalva was an 18th century Italian who first coined the term Eustachian tube or Eustachian tube after his predecessor. And Valsalva provided the first function of the Eustachian tube, which was that he thought it was to aerate the middle ear. So we now know there are three functions. One is ventilation of the middle ear space. The second is it has to clear dead cells, debris, and fluids from the middle ear and the mastoid into the nasopharynx. And there is mucociliary clearance with cilia that are kind of beating towards the nasopharynx. And then the third is that it has to prevent reflux of sound and secretions going up to the ear. And so what you'll notice is that some of these functions require that the Eustachian tube be open. And then this one here, preventing reflux, requires that it be closed. And so what's important to think about the Eustachian tube is that it's dynamic. It's a valve. So it has to have muscular action that opens it, and then it has to stay closed most of the time. And how that works is by action of these two muscles here. So the tensor muscle and the levator muscle. So when the first thing that happens is the levator muscle contracts, and this swings this whole cartilage body on the skull base, on these suspensory ligaments. And then the tensor muscle contracts to open the Eustachian tube and create this lumen here, which allows some air to percolate up to the middle ear space. And we'll keep revisiting that. So I'm going to show you what this looks like on this muscular action on endoscopy. So this is a 45-degree rigid nasal endoscope in the left nasal passage, and it's looking at the left Eustachian tube. This area back here, this is the fossa of Rosenmuller. So always have to look here to look for nasopharyngeal carcinoma. This structure here is the torus tubarius, which we just saw on histology. This is that anterolateral wall, and within this is the tensor veli palatini muscle and Ostman's fat pad here. So when this partially opens, you can start to see that this cartilage body starts to swing upwards as the levator muscle, which is in the palate, starts to contract. The tensor is still kind of relaxed, and that's why there's an obstruction here. But when there's a full elevation of the cartilage and the levator muscle, that's when the tensor fires, and it creates this little opening that then goes up to the middle ear space, and that's what allows ventilation. So this is a video of that exam. So the endoscope's being 45-degree. A 45-degree scope is really helpful to look down the lumen of the tube. This is someone saying ka, 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 and then you're going to see them swallow here, and then a yawn for maximal opening of the tube. So those are the three maneuvers that I always have patients perform every time I look in their Eustachian tube. There's again another swallow. And what you want to see is the swinging of this torus upwards. You want to see this muscle contract at the right time when this is rotated up and making a little opening here. And at rest, you want to see this convex appearance here where it's kind of bulging out to the lumen. That's a normal, healthy appearing Eustachian tube. So to sort of emphasize the importance of the simultaneous action of these muscles, there was this interesting study that Kunyat Alper did, published in 2012, where they did needle EMGs of the tensor muscle, the levator muscle, while they had an endoscope in the nose and they had sonotubometry being performed. So that's basically a manometer in the ear canal, just like tympanometry, and you're playing a tone. And so these sort of brave individuals underwent all of this testing to show that the contraction of the tensor veli palatini muscle and the levator veli palatini muscle happen almost simultaneously when someone is swallowing in between these lines here, which is then followed by a change in pressure that can be measured on sonotubometry. And then if they look at the video of the different parts, when they slow it down into its individual frames, what they first start to see is the levator muscle starts to activate, followed by the swinging of the cartilage on the skull base. Then the tensor muscle contracts and the eustachian tube opens. So it's the combination of those two muscles, which is really important for normal opening of the eustachian tube. This is another study by McDonald et al., again in 2012. They did a cine CT where they took 16 contiguous slices over just a small 4-centimeter area. And then they took that continuously every 4.8 seconds while someone was swallowing. And what they saw is that there was this little bubble of air that formed right at the entrance of the eustachian tube and then sort of percolated its way up towards the middle ear space, suggesting that there might be some peristaltic activity of a bolus of air as it's kind of being projected up towards the middle ear. All right, so why do we even have to get this bolus of air up to the middle ear? I have to just briefly cover middle ear gas exchange, and I'm going to try and make it really simple. So you know at this point that the way that the middle ear works optimally is when the pressure behind the middle ear, in the middle ear space, is the same as the outside air. So atmospheric pressure is 760. When the middle ear total pressure of all the gases is 760, then the system is optimally functioning and we can hear well. The composition of the gases in the middle ear space is not the same as that of the atmosphere. And the big gradient, the big transition of gases out of the middle ear occurs into the venous blood. So the total pressure of gas in the venous blood is much lower, and that of nitrogen, oxygen, and CO2 are all lower. So the first thing that happens when is that the oxygen and the CO2 begin to rapidly diffuse down their concentration gradients. And it's not a big difference. Oxygen is not that much greater than venous blood. CO2 is not that much greater either. The biggest difference happens because of nitrogen between the two. And nitrogen diffuses a lot more slowly. So nitrogen kind of is the biggest gas, but slowly diffuses over time. And so what happens if you get an obstruction here, and you can't regulate the pressure in this space. So you can't swallow and yawn and put a little bit of air up here to make the pressure the same as the atmosphere. If that happens, then the gases absorb into the blood and you get some negative pressure in this space. And the eardrum starts to retract. And it first retracts in the pars flaccida because it's less reinforced, and then it retracts in the pars tensa. And if the pressure builds up enough, you can actually pull in fluid through the interstitial spaces. So that's often where we think the effusions might come from, is the fluids being pulled in through the interstitial space, filling up the middle ear and creating an effusion. So there's a really interesting study by the Sade group in which they took some healthy volunteers and measured tympanometry sequentially while a person was told, don't swallow. And in fact, what they did is they kind of held their tongue in place and then just recorded tympanometry over time. And what they saw is that at first you start with a type A tympanogram, and then over time it becomes increasingly negative. And so if you look at the peak pressures here of one individual that held their tongue for 2 hours and didn't swallow, you can see that over time you start to get this increasingly negative pressure that becomes significant for what we would consider eustachian tube dysfunction after about an hour and a half or 2 hours. So another important thing to keep in mind is that otoscopy doesn't necessarily correlate with eustachian tube dysfunction. There are other things that can cause it to look like it's an obstructive eustachian tube problem. So for instance, if you have a middle ear effusion, yeah, it definitely could be caused by an obstruction of the eustachian tube, but it also could be caused by an inflammatory process that's occurring, such as an autoimmune condition. You can also get something that looks like this, in which this person clearly had a history of eustachian tube dysfunction, but at this point, they've got erosion of the distal incus, they have atelectasis on the cochlear promontory and over the round window, and actually their eustachian tube may be functioning just fine, but when eustachian tube dysfunction occurs over a long enough period of time, these adhesive processes happen, and the eustachian tube, and then whatever the eustachian tube is doing, you can still look like you have a retraction. Probably the best indicator of active eustachian tube dysfunction is negative pressure on tympanometry. So if you had something like this, where you had a pars tensa retraction, and they had negative 170 on tympanometry, you can be really sure that that person has an obstructive eustachian tube dysfunction at this moment. So our next stop is interventions for the eustachian tube. It really didn't take long after Valsalva suggested that there might be a function of ventilation before surgeons started to innovate. And what they first started doing is taking these long catheters and sticking them into the eustachian tube and then injecting a bunch of stuff there. They would put air to try to inflate it. They had canisters of air that they would kind of inject. They would put various poultices and things like that on the eustachian tube. And in some cases, they would kind of listen with their ear on the ear canal while they injected air to see if air was kind of transmitting up to the middle ear space. And so the first eustachian tube catheterization was performed in 1724. You can look back into old textbooks and see these really interesting ways that they would feel their way back there. I mean, basically, they didn't have any endoscopes. And so what they were doing is kind of sticking these instruments in blind and sort of feeling these clicks of the cartilage as they basically kind of made their way back to the eustachian tube. Unfortunately, people died. There were several kind of prominent cases in which air was injected into a submucosal tear, and the person got mediastinal emphysema and died. And in fact, 2 young people did in a short period of time. There were also carotid artery injuries because the carotid artery is, as you know, really close to the eustachian tube, particularly at the bony isthmus. And so for a long time, interventions on the eustachian tube were considered off limits in otolaryngology. And so that's why we didn't do them. People started to try to do this more safely. So in 1905, Hayes tried to use this eustachian tube endoscope, which was basically an angled endoscope inserted through the mouth. And then you can see this is the catheter in the eustachian tube here, with the endoscope looking up towards the nasopharynx. But nevertheless, it really didn't pick up until recently. Another important lesson that we've learned over the years or century, really, is that the cartilaginous eustachian tube is likely to be the site of the obstruction. So remember, about 2/3 of the eustachian tube is the cartilaginous part. It has this really narrow area called the isthmus, which most people would assume is the rate limiting step when there's an obstruction. So several groups from Germany, France, and Japan used microendoscopy to explore the eustachian tube in people who had obstructive eustachian tube dysfunction. So in this series from Japan, what they did is they inserted this little microcatheter into the cartilaginous eustachian tube, and they had a little pressure test in applying negative pressure in the middle ear space. And what they were trying to figure out is, where's the site of obstruction? If I could advance this far enough, can I get past it? And what they found is that in 8 of the 10 subjects, if they advanced this little microcatheter partly through the cartilaginous eustachian tube, they could bypass the obstruction. And in only 2 of the 10 cases was there continuous obstruction, even at the bony isthmus. The next point is that surgeons tried to decompress the bony eustachian tube in different ways. So Wolstein in 1960 tried a middle ear approach where he kind of widened the orifice of the eustachian tube. Glasscock and House showed this approach here, where it's a middle fossa approach of decompressing the isthmus, which was assumed at that time to be the problem. And then others did kind of a post-auricular approach using different stents to try to open the isthmus. And you just have to keep in mind, of course, is that the carotid artery is really close to the isthmus of the eustachian tube. There were carotid artery injuries from these approaches, and there were no reports of long-term success. And so most of these have generally fallen out of favor at this point. This is some examples of inflammation around the eustachian tube. So this is a right eustachian tube. And you can see a couple things. There's this sort of polypoid edema of the torus tubarius. There is some kind of prominent adenoid tissue as well. But when this person is yawning and most of the time when they're swallowing, they're able to, the eustachian tube was able to open okay. This is that's a slow motion version right there, just to show that it is opening in that case. This is a more extreme version here. of somebody with a severe obstructive eustachian tube problem. And this eustachian tube is just not opening at all. And you're seeing one interesting observation that we often see, especially in people with bulky adenoid tissue, which is that this torus, instead of rotating, is actually kind of being plunged or pushed forward towards us. And at exactly the moment that the eustachian tube should be opening with a swallow or a yawn, it's actually being obstructed by this kind of bulky torus and probably by some bulky adenoid tissue behind it. So here's the kind of a slow motion view of it kind of obstructing here. And this is a really nice, these are both videos from Dennis Poe. So there's more than one grading system for eustachian tube inflammation. This is just one based on the endoscopic appearance, with grade 1 being normal, grade 2 being kind of mild inflammation, but the person is able to open the eustachian tube. Grade 3 is moderately inflamed mucosa, but you're still able to, again, open. So more severe inflammation than this, but that was the example on the other slide, the first video we saw. The person was still able to open. And grade 4 was a severely inflamed mucosa with inability to dilate the eustachian tube. So one thing that I think is really important to review is the differential diagnosis for ear fullness. I have a clinic focused on eustachian tube patients. However, the vast majority of the patients I see don't come in with obstructive eustachian tube dysfunction. They come in with this complaint, which is ear fullness, the fullness or pressure in the ear. And so the way that I think about it, the way that I've been taught to think about it, is to first examine the eardrum, and that can be grouped into two things, either a normal eardrum or something that's retracted. So if the person has negative pressure, type B or C tympanogram, and importantly, if they've had relief of symptoms when they've had a myringotomy or a tube, then that suggests that this person has an obstructive eustachian tube dysfunction. I always do nasopharyngoscopy on these patients. I'm looking for evidence of inflammation around the eustachian tube. And I know you're all neurotologists, or many of you are. It's not difficult to get in the habit of doing this. We've all been trained in rhinology, and it's quite easy actually to do, and it gives you a lot of information. So that's the classic obstructive eustachian tube dysfunction. Now, if someone is, yep, go ahead.
Hey, this is Nate Cass from Vanderbilt. Hey, do you typically scope people with rigid or flexible scopes?
So I tend to focus more on the flexible scope because what is nice about it is you can easily see both sides through the same nasal passage. And if you need to look for, if someone has chronic otalgia, I always do kind of a comprehensive laryngoscopy. So I would do it then. Most of the time, I'm just focusing on the nasopharynx. And what I'll do is I take the flexible scope, and if you turn it 90 degrees, then you can kind of flex it in both directions. So you can see both eustachian tubes through the same nasal passage. You do have a better view of the contralateral side than you do for the ipsilateral side. The quality of the camera is better for a 45-degree rigid. And so in the operating room, I use that. But most of the time, I just use a flexible.
Great, thank you.
Sure. And for any of you, please, feel free to just interrupt at any point and just ask me questions. I'd love to be stopped. All right, so for a normal eardrum, so if somebody has a baro challenge problem, so say they're a scuba diver, or every time they're on an airplane, their ear feels full for a couple days afterwards, I'll do a nasopharyngoscopy, and I will talk later about one of the pieces of pathology that you can sometimes see on those folks. But at sea level, they often have normal tympanic membranes. If somebody has autophony of voice or breathing, and I ask them to breathe in and out through their nose, and I can see their eardrum moving, this can be made more sensitive using a special tympanogram, which we'll talk about later. That's an example of Patulus eustachian tube dysfunction, which we're going to talk more about. And then something I really want to kind of teach you guys about is the sniffers. So if you will see people in your clinic who are sniffing frequently, and they often say, why do you doing that? You're like, well, it makes my ears feel better. And so this can be confusing because these people can be patulous, and in fact, probably are patulous, but will have a retracted eardrum, so you'll think that's an obstructive problem. So why are they sniffing? So this is, a little model of the eustachian tube here, nasopharynx here, middle ear here. If there's a problem where there's an obstruction of the cartilaginous portion of the eustachian tube, the right way to kind of relieve that would be a modified nasal valsalva, where you're basically forcing some positive pressure from the nasopharynx, dilating the walls of the eustachian tube and putting some pressure up into the middle ear space. So that makes sense, and that's what we tell people to try to pop their ear. And so that will open the cartilaginous eustachian tube. On the other hand, if somebody has an open eustachian tube and they sniff in through the nasopharynx, they're generating some negative pressure and pulling the walls of the eustachian tube closed by this kind of Bernoulli effect. And what they're often trying to do is to close their eustachian tube, because both in a patulous and an obstructive eustachian tube, the ears feel full. And so, but it's so confusing because when you look in, you'll see this retracted eardrum here, and you're like, this can't be a patulous. So beware these frequent sniffers. So then there's folks who don't have any baro challenge, they don't have any autophony for breathing, and they don't have any excursion membrane. Maybe we even put a tube in or did a myringotomy, and they're like, that didn't help. In fact, the tube made it worse, and I want that tube out now. So other things that can cause a sensation of ear fullness, migraine, endolymphatic hydrops, Meniere's disease, third mobile window syndromes like superior canal dehiscence, and probably by far the most common thing that I probably see in my clinic, I would say, is temporomandibular disorders. They may have tenderness in and around the joint capsule. I always will do an intraoral exam, and I'll just show you how I was taught to do this. But they may just have a sensation of fullness or pressure, and muscle tightness can cause the sensation of fullness in the ear. So what I'll do is I'll feel around the joints. I'll feel the temporalis muscle. I feel the joint itself. I have them open their jaw and move it side to side. I press underneath the angle of the jaw. Oftentimes that's tender, or it kind of modulates their sensation of fullness. And I try to feel intraorally for the lateral and medial pterygoid muscles by kind of passing my finger along the inner border of the mandible or up the maxilla here. And you'll sometimes see people kind of just like recoil out of kind of discomfort when you kind of touch on this muscle. And it's worth just trying on yourself just to kind of get the hang of it. But I do this on just about every patient that has a sensation of ear fullness. And you'll find that this muscle in particular is often really tight and is probably related to bruxism. All right. So in the rest of the talk, I'm going to discuss the three classes of eustachian tube dysfunction here: obstructive, baro challenge, and patulous, as they're currently defined anyway. First, I'd like to comment a little bit on epidemiology. There's a lot of data on pediatric eustachian tube dysfunction. We recently looked at the prevalence in adults using tympanometry from NHANES and found that there's about 4.6% of the adult population has negative pressure on tympanometry, just of kind of the general population. So it is almost as prevalent in adults as it is in children. And I think it's just underdiagnosed or underappreciated. So you're definitely going to see this in your practice. The interventions, so modified Valsalva maneuvers. And when I say modified, what I mean by that is I tell patients not just to hold your nose and blow until they can pop their ears, but they should generate some positive pressure by closing their nose and blowing, and then swallowing against that pressure. And it's that swallowing maneuver that activates that tensor and the levator muscles. And with a little bit of positive pressure is often enough to kind of safely open the eustachian tube and put a little positive pressure up there. If you don't do that modified part, you can always force enough pressure to blow up towards the middle ear space. But the pressure gradient may become too high and you can actually cause some damage. Medical, intranasal steroids are not effective for otitis media of effusion or obstructive eustachian tube dysfunction. They may just not get to the right spot, but the Academy no longer recommends this as a treatment for obstructive eustachian tube dysfunction. When I see a patient and think about medical management, I want to address causes of inflammation. So smoking, gastroesophageal reflux and nasal allergy are the biggest contributing factors for inflammation around the eustachian tube that causes it to be more difficult for them to open it when they swallow and yawn. And then for procedures, so tympanostomy tubes and balloon dilation of the eustachian tube. So the first myringotomy was performed in 1801. You can find the paper online by this guy, Astley Cooper, in England. And he noted some patients had holes in the eardrum but had minimal hearing loss. And so he thought, well, maybe I'll try to make a hole in the eardrum to see if I can make the patient's hearing better. And you can almost sense how shocked he was that it worked. This is the device he used to make an opening into the eardrum. There were no audiograms. And so he writes in the discussion that the apothecary will attest to the improvement in the patient's hearing. So you just have to contact that apothecary to kind of confirm his results. But that was the first myringotomy, and it took about 100 years before we started putting grommets in the middle ear to keep that opening present for longer. But it's an effective way of just bypassing the entire eustachian tube. You keep the pressure behind the middle ear of the space the same as the outside world all the time, at least until the hole closes. So balloon dilation of the eustachian tube is this kind of hot new topic that I'm sure you're all seeing a lot in your clinics or thinking about and trying to puzzle over who's the right patient to get this intervention. This is the first device that was approved by a Clarent, and how it works is you've got a little pressure gauge here. This particular device I think costs about $1,100. The balloon itself is only about $170. So, and of course these are disposable. But that's why you're struggling with insurance companies to pay for these. The basic structure is that you've got this guide catheter here that introduces the device into the eustachian tube. It has a tiny little balloon here and a rounded tip on the end of the catheter so that it doesn't go into the isthmus. So it's designed to stay in the cartilaginous eustachian tube. The balloon inflates just in the opening of the cartilaginous eustachian tube, and at least in this device, there's a little hole through the lumen of it so that it kind of helps relieve pressure, back pressure. So this is what it looks like just in 4 snapshots. The guide catheter going in on the right side here. This is the inferior turbinate. This is the torus guide catheter, and then the balloon itself is inflated or inserted off of the guide catheter into the eustachian tube. You'll encounter some resistance, then you pull the catheter back, you inflate it typically to 12 atmospheres of pressure. We usually keep it there for 2 minutes, and then you pull the whole thing out and inspect. So just a reminder that it dilates the cartilaginous eustachian tube. So in this, I'm sorry for all of these goofy drawings. I make these myself. But this balloon catheter gets inserted here. It doesn't go into the isthmus. Reminder, this is where the carotid is, close to the bony isthmus. And it just dilates the cartilaginous portion here. The indications for this are people that have persistent otitis media with effusion or non-adherent atelectasis. So what I mean by that is that it looks like the eardrum's kind of retracted in and they can pop it, or you can kind of pull it or separate it away from the middle ear space, from the cochlea and the medial wall. They have to have a type B or C tympanogram, and then obviously they have to have symptoms of obstructive eustachian tube dysfunction. I often like to see that symptoms have gotten better with either a myringotomy or a tympanostomy tube. Like I said, most of these patients that I see in my clinic who come in for years of ear fullness often have like TMJ or some other cause that is not the eustachian tube. And then people with flight or scuba barrow challenge tend to do well, but they are not part of the current indications as part of the insurance practices. So this is a video. This is my first time ever doing this. This is when I was with Dennis. Just to show that it's not too hard. I know you guys are neurotologists, but I think you can all do this. So this is a 45-degree scope. This is the guide catheter being inserted below it, along the floor of the nose. You basically just rotate it out towards the lumen of the eustachian tube. It's helpful to see the lumen here, and then you insert the balloon off of the guide catheter. It should go in nice and smooth. At some point, you're going to reach some resistance. At that point, then you hold the balloon in place and pull the guide catheter back. And what you want, and as you can see, I'm kind of flailing a little bit. I don't really know what the right pressure is, but it's okay. It all turns out fine. The yellow part should be outside of the lumen of the eustachian tube, and then you inflate it with saline up to 12 atmospheres of pressure, and then just sit there for a while. And I am not going to sit here for the whole time, but those 2 minutes last a while. Then you deflate it, or you have your system deflate it, and then pull it back into the guide catheter and just remove it and inspect to make sure that you didn't get into any false passages. And that's it. That's the whole procedure. So what's happening when you balloon dilate? So this is a cadaver study that, that Dennis and colleagues had done in 2011, or published in 2011. And what they found is that after the balloon dilation, this is distance from the eustachian tube orifice, the area where the balloon was inflated after dilation, the cross-sectional area, is larger, unsurprisingly, in the space where the balloon was inflated. So pre-dilation is in red, post-dilation is in blue. So yes, at least immediately after dilation, it seems like it gets a little bit bigger. But probably the way it is most likely working is shown with this study, where they took some biopsies from the mucosa before dilation, immediately after dilation, and then 5 weeks later. And so what they found is, if you look at the 5 week later biopsies and compare the after to before, what they saw is that before there was this kind of these heaped up, really thick mucosa and lymphoid follicles. And afterwards, you had this crush injury, and you started to see this hyalinization form, where it was basically scarring, and there were fewer lymphoid follicles and fewer lymphocytes. And so this happens in other places in the body where you can insert a balloon, like angioplasties and biliary duct procedures, that you kind of get this scar formation. So it forms a wider lumen and slightly bigger in the end, long term, because of that scar. So clinical evidence for this. So this is the paper, the data that the FDA used for the study. This was a randomized controlled trial in which the primary endpoint was a type A tympanogram 6 weeks after balloon dilation of the eustachian tube. And people were randomized to either get what they thought of as medical management, which was nasal steroids, but was obviously not particularly effective, or this procedure. And this was the key point, was 6 weeks, whether they had a type A tympanogram. And what they found is that in those that had the medical management alone, about 20% had a type A tympanogram. So before, almost everybody had type B or C. There was this one outlier, I think, that just barely didn't have the negative pressure for it. But then afterwards, 20% of the medical management had type A, and almost 60% of those that underwent balloon dilation had type A. So this was enough for the FDA to say, yes, it seems like it's effective, or the efficacy warrants approval, and that's where it was granted. They followed these people out to 12 and 24 weeks, and then a full year afterwards. The problem was, after this endpoint here, anyone who was in the medical management group was allowed to then switch over into the balloon dilation group. And so they found that at 1 year in their follow-up study, a similar percentage, about 60%, had a type A tympanogram, but it wasn't always the same folks. And so it seems like it has a durable effect. We really don't know how long it works, though, at this point. There was a second randomized controlled trial using a different device, this one by Stryker, now by Stryker. And they had a slightly different endpoint. They used this thing called the Eustachian Tube Disorder Questionnaire 7. So it was a quality of life metric. And they found that there was a significant decrease in those that underwent balloon dilation procedure that wasn't there in the controls. Also used the 6 week point. So complications. So there can be some bleeding. They're not always as clean as that kind of that video I showed you. Sometimes people have really big septal spurs and it causes bleeding. And unfortunately, where it bleeds is right onto the eustachian tube. So I wouldn't recommend doing a septoplasty before doing a balloon dilation procedure. Bleeding is usually pretty minimal, though. You can get some lacerations of the anterolateral wall that can create a false passage, as shown here. Some people have had emphysema reported, subcutaneous emphysema. I tell patients to avoid nose blowing for 1 week after the procedure. Here's an example of one of the cases that's been reported of just sub-Q emphysema. No serious complications in these folks, at least has been reported thus far. They usually are just treated with antibiotics. Some are admitted overnight. I haven't seen it yet. Patulus eustachian tube definitely happens, probably in up to 10% of cases. Most of the time, it's a short-term thing, but I've seen patients because of this eustachian tube practice that have had patulus for years, and some of whom have become suicidal as a result of it. So it's you have to make sure you got the right candidate for this procedure. There haven't been any reports of infection, scar, worsening obstructive eustachian tube dysfunction, or carotid artery injury. Nothing in the literature, as far as we know. There were rumors, but I haven't heard it ever substantiated of one that happened in Europe. So, folks who have Barrow challenge, when you look at their eustachian tube, you often see these strange, like redundant bands of tissue here. And I see this more and more. Dennis Poe pointed this out. Maybe at some point we should call these Poe's bands. So I'm gonna recommend that to all of you. Start calling it Poe's bands. But you'll see these in folks who Barrow challenge, and they seem to respond really well to balloon dilation if you can get insurance to cover it. So the conclusion is, balloon dilation seems to affect it by stripping the mucosal lining. It crushes the infiltrates and follicles, healing with less inflammation. Indications: irreversible mucosal disease, cartilaginous disease, B and C TIMPs. If they've had tubes before, that's really helpful. Sometimes they've had flight or scuba trauma. And I always have to look for any evidence of pathology on the eustachian tube. If I don't see that, then I'm less inclined to want to do this procedure. It can be combined with chronic ear surgery, although insurance is usually not supporting this. And it's going to take a long time for us to figure out if it's effective, for instance, in preventing additional tympanoplasties or something like that. We need better science on the effects of eustachian tube dilation. We need better indications for children who inevitably are going to have this done more and more commonly. It's currently only FDA approved for adults 18 and older. We have done some children at our institution. I think the youngest has been 9 years old. The duration of effects are still unclear, especially with respect to whether tympanostomy tubes are better. So I want to talk about patulus eustachian tube for the rest of the talk. And I think it's really underappreciated. So if you look in this ear, you'd assume that this person has a retraction and obstructive problem. But if you just ask them to start breathing in and out through their nose, you start to see that, in fact, their eustachian tube is not obstructed. They're clearly passing air there. In fact, every time they take a breath in and out, the eardrum is moving with respiration. So this is somebody with a patulus eustachian tube, despite the findings here. And they might be somebody who sniffs in all the time, and so maybe you think it's obstructive. So we looked at all of Dennis Poe's patients. So he had 190 patients with definite patulus eustachian tube. The age of those folks were around 38, equally men and women, equally prevalent in the right or left ear, and bilateral in about half the time. And the presenting symptoms that these patients have are breath autophony. So that is when they breathe in and out through their nose, they can hear their nasal breathing loudly in the ear. Their voice sounds loud or distorted in that ear. So they'll often describe it as, it sounds like I'm talking in like a bucket or a barrel. They'll have earfulness, just like if they were obstructed. Some people will have hear pulsations, probably from the carotid artery, which is nearby. And others will just say, it sounds like crackling or rumbling. I'm not really sure if it's my breathing or not. There are a lot of modifying factors. So it typically is worse with exercise. Some of you may even notice that when you're exercising, you'll get this temporarily in one or more, both ears. It's typically better when the head is dependent. So they won't have symptoms typically first thing in the morning. It's usually better after they've kind of lied down for maybe 15, 20 minutes, it goes away, and then they get up again, and it happens within a few seconds or minutes after getting up. It gets better when they sniff, often. It sometimes is better when they press on their internal jugular vein. And the way that this probably works is it backs up venous pressure into this plexus of veins around the eustachian tube and helps close it. So this is also thought to be the reason why it's better when they're head dependent. So when they're lying down, you get some relative swelling of the veins around the eustachian tube and it closes it. And then when they get up, that kind of drains and it opens again. Sometimes it can be better when they have an upper respiratory infection. The symptoms are progressive in about 2/3 of patients, becoming more frequent or persistent or affecting both ears. And then in terms of different comorbidities, we looked at a bunch of different medical issues that were listed. And we found that some, like oral contraceptive use, smoking, and migraine, were about what we would expect in the general population. Others, like weight loss, is known to be a risk factor because of that fat pad around Ostman's fat pad. That can make people get patulous eustachian tube dysfunction, but the weight loss range was huge, from just a couple kilograms up to 115. And weight gain was tried in 7 patients, but only 1 had partial improvement. And so we don't recommend weight gain for people with patulus unless they're underweight. Some conditions like neuromuscular disease, autoimmune conditions are more prevalent than the general population. And then what was a kind of a surprise is that a history of environmental allergy prior otitis media was much more prevalent. And then we had 3 people that had 3% had superior canal dehiscence, which is a lot higher than we'd anticipate. So on nasopharyngoscopy, here's a normal eustachian tube. Here's one that's patulous. And what you see is there's this concave deformity of this interolateral wall, where it's almost kind of like shrunken in instead of convex, which is bulging out here. So I'm going to show you what, this is a flexible exam. So looking from the contralateral side at the left eustachian tube. And this in the front wall here is where that kind of concave deformity is, where you can almost see that the tissue is sort of retracted or shrunken back because of either, well, a number of different reasons, which I'll talk about in a second. And if you look up, you can kind of sometimes see a little area like a black lumen that kind of goes all the way up towards the isthmus. So different causes of patulus, basically anything that can affect the structures of the eustachian tube can contribute to patulus. So the one that people think most about is weight loss because of loss of Ostman's fat pad. But that wasn't the majority of people in the group. There's a lot of folks who have patulous eustachian tube that don't have weight loss. So other contributing factors are possibly atrophy of the mucosa. If you think back to about that one picture, it looked like the mucosa was shrink wrapped onto the cartilage underneath of it. And so that might be a consequence of chronic inflammation like allergy or reflux. And then some folks have chronic tension on the tensor veli palatini muscle. They're really anxious. They may have temporomandibular disorder, and that muscle is chronically contracted. So treatments for this, behavioral. So the first thing is just to educate them on what's going on. Different body positions can help. If they get dehydrated, it's more likely to happen. So they should avoid things like caffeine and decongestants. Caffeine is kind of a trigger for a lot of people with patulus, and certainly anything that's kind of made to kind of decongest them, which is common because people are often treating obstructive issues, but it's really patulus. After behavioral stuff, then we talk about medical management. What I start with is just topical saline. So I teach them on how to get the saline to the right space by showing them, okay, if you lie down in a Dix-Hallpike maneuver, and then you put the drops in the side on the, like, so for instance, you go in the right Dix-Hallpike, you put it in the right nostril, and it drains straight back to the surface of the eustachian tube. And that's how you deliver the medicines right to the eustachian tube. And the same thing for the left side. You go into the left Dix-Hallpike maneuver, put it in the left nostril, and it drains straight back. For topical saline, then it doesn't burn, it doesn't irritate, but sometimes the moisture is enough, and that moisture will just kind of help relieve symptoms. And they can use this as much as they need. If this topical saline isn't enough, then I go to hypertonic saline. So what I do is I'll tell them, take a cup of water, take 3 teaspoons of salt, mix it in, and then put it in a little eyedropper bottle that they can kind of purchase online. from Amazon or something. And that eyedropper bottle is important because you don't want to just spray hypertonic saline all over the nose. It'll burn like crazy. But what you want to do is deliver drops so that it gets to the surface of the eustachian tube. And when they hit the right spot, they'll know because they'll feel this little twinge of pain that goes up towards the ear on the same side. And right after that, if they get up, they will notice that their symptoms are better. And the duration of improvement of symptoms varies. So it can vary from 12 hours to as short as just a couple minutes. But it can be really helpful if you're kind of not quite sure if the person has a Patulus eustachian tube. If they're like, oh yeah, I used the hypertonic saline, I hit the right spot, I got up, it was definitely better, but it only got better for like 15 or 20 minutes. Premarin is a hormone that has to be specially compounded, progesterone at a compounding pharmacy. It's usually very expensive. The mechanism is likely similar in that it causes some mild inflammation. So hypertonic saline causes inflammation of the mucosa and it swells, and that's why that gives them relief. Premarin would do something similar. There's also, they can buy something online called Patulus, which is vitamin C in a bottle, and it does something very similar to hypertonic saline. Potassium iodide has no studies to support it. It's taken orally to thicken secretions. In fact, there are no studies positive or negative about potassium iodide as far as I could tell. And then procedures. So tympanostomy tubes is often talked about. I more often than not see patients who've had tympanostomy tubes and hated them and wanted them removed immediately afterwards. Some people probably do seem to get better. And I think if it works, it's because it's a mass that kind of sits on the eardrum and prevents it from moving or vibrating. There have been studies, good studies that show that mass loading of the eardrum can often help them help the autophony symptoms and the of voice and breathing. So what I'll often do is I'll consider putting these paper strips on the eardrum, like just basically cutting steri strips and layering it on, and then seeing, did that help you? And I'll have them kind of walk around for a couple of days. And if they say, oh yeah, it made a big difference, but 2 weeks later my symptoms came back, then you can consider doing a cartilage tympanoplasty as a longer lasting solution. And I have done that in a handful of patients. And then there are eustachian tube occlusion procedures. So the first that was reported, this is Charlie Bluestone's technique of placing a shim in the eustachian tube. This is from the middle ear side. So this is an angiocatheter that's filled with bone wax. And it's cut to the size of the bony eustachian tube and slid in place. And you can either do this with an anterior tympanometal flap or with an anterior myringotomy. And then this is the approach I learned from Dennis Poe. Again, this is a Patulus patient, and what you're going to see is a shim being inserted from the nasopharynx. And so what we do is we take an angiocatheter, like a 14 or 16 gauge angiocatheter, you aspirate up some molten bone wax and then cut it to the size of the eustachian tube. And then there's this special insertion tool that Karl Storz sells. It's only like $100, easy enough to get at your hospital if you're interested. It's basically a plunger that goes in through the mouth, and you insert this into the isthmus of the eustachian tube. So this one is designed to go into the isthmus of the eustachian tube. It has these radio-opaque strips so that you can see it if you needed to. And that's it. You kind of leave it in place, and it occludes the eustachian tube. You check the middle ear, just make sure you don't see it on the, up here, that you didn't push it in too far. Other approaches are injecting hydroxyapatite cement, as is shown here. So this kind of angled needle filling up the anterolateral wall. It's difficult to kind of find a pocket to inject in along the cartilage posteriorly. So most of the injection happens in the anterolateral wall. So I looked at the data from Dennis's procedures where he had done about 240 cases. And what I found is, if you can break these into kind of 4 general categories. One is this, which is complete obliteration. So if you totally obliterate the eustachian tube, which was rarely done, I think it was done in like 6 patients or so, it does make the symptoms go away. But you get some different problems, which is chronic mucoid effusions, and it's really a last resort. It's very difficult, obviously, to reconstruct a eustachian tube. The second is the shim insertion, which is shown here. And the shim, surprisingly, had really good results all the way up to 12 months. So this is complete resolution of symptoms at 1 year. And for all procedures, 2/3 of people had complete resolution of symptoms. And if this was their first time, 75% of people had resolution of all symptoms with a shim. And so that's why I tend to offer this more, this and the mass loading procedures. With the Patulus eustachian tube reconstruction procedures, these are different ways of inserting cartilage or fat or other materials in submucosal pockets to kind of permanently decrease the lumen of the eustachian tube. And ideally, you'd want to do something like this, or maybe an injection of hydroxyapatite. The problem was that the results just weren't as good, particularly for the hydroxyapatite. And so that's why I've chosen to use the procedures I do. All right, so my conclusions are eustachian tube dysfunction is nuanced. Balloon dilation is a new treatment of obstructive eustachian tube dysfunction, and in the right cases, I think it's effective. Patulus eustachian tube dysfunction is probably a lot more common than we once thought, has multiple etiologies, but most of the time, that is in the majority of people, it can be treated medically. I need to give special thanks to my colleagues, residents, and statisticians, and of course, Carrie Neiman at Johns Hopkins, as well as Boston Children's, to Dennis Poe, who's been just a terrific mentor, and to his great team of folks up there. So thanks so much, and I'm happy to answer any questions.
Thanks, Brian. Quick question. I know you said that it's really hard to get eustachian tube dilation and tympanoplasties sort of concurrently approved by insurance, but could you just describe sort of the times where you would really want to do both at the same time, and if you have sort of any type of quick, like, yes, this is definitely going to be someone where I'm doing both at the same time, or else the tympanoplasty will fail?
Yeah, so I heard recently that, just a remark about the insurance thing, that many insurance companies are not approving this if it has any other codes besides something like a myringotomy or tube with it. So no nasal procedures, no other ear procedures. So it has been difficult to get approved. In terms of who would be ideal for this, I think somebody who's had a prior attempted tympanoplasty and failed, and you look in their eustachian tube and you see that they have kind of evidence of significant inflammation, and they've tried medical management and it just hasn't significantly improved, then that would be somebody I'd be really tempted to want to do the procedure at the same time. Because the success rate of tympanoplasty is already so high, creating a study for this would probably require upwards of 1,000 participants. So it's going to be a long time before, if maybe never, before we know if that's an effective treatment to do at the same time.
Thanks.
Sure.
Hey, Dr. Ward, this is Nate from Vanderbilt again. One other question: if you have a patient that has patulus and you put a shim in, and they're bothered by their resultant persistent oral fullness, conjunctive hearing loss from persistent effusions, do you preference taking the shim out, or will you do a tube? Like, how's your branch point on that?
Yeah, exactly. So the nice thing about the series, so Dennis Poe, at least up until that point when I was working with him, had not traditionally put a tube in at the same time. So it allowed us to see that, well, if you had good relief of symptoms, did you actually need a tube? Did you have otitis media with effusion? And the majority of people did. So at this point, I consistently put a tube in, whenever, a tympanostomy tube, whenever I put a shim in. And often when people call me and say, hey, I think the shim is out, what usually happens is that the tube has fallen out and they've got a effusion. So their patulous symptoms aren't there, but their voice is slightly different because of the effusion. And so if you put another tube in, that usually gets better. So I'll typically just replace tubes before removing the shim.
Okay, thanks.
Dr. Ward, question.
This is Nate Lindquist. Oh.
Go ahead.
I had hopefully a couple quick ones, but this is Nate. I'm the first-year fellow from Vanderbilt, also Nate. And I was just going to ask, do you routinely get CT scans on these folks if they don't come with one and you're considering the procedure? And my second question is, in a patient who's had radiation to the temporal bone and presumably has dysfunction, that isn't due to, radiation effects on the mucosa and a clear opening? And would you consider doing that, dilation for them, or is it something you would probably treat more with a tube, or what's your kind of strategy on that?
Yeah, so the first question, so if any patulous procedures that I'm kind of manipulating the bony eustachian tube or the isthmus, I'll definitely get a CT on, because I want to make sure that the carotid isn't dehiscent. So if there was a dehiscent carotid, I wouldn't put a shim in, and I would favor more like mass loading, or potentially like a submucosal flap, for instance, like Dennis often does. However, for balloon dilation of the eustachian tube, the FDA, it's still in their listed, the recommendations is to get a CT scan to make sure that the anatomy looks fine. The utility of that, I think, is kind of questionable. And so I'm less and less inclined to want to get it, but it's still part of the FDA recommendations. Yeah. And for radiation, it's a really great question. It seems like, so if people have had radiation to the temporal bone, you put a tube in, they hug you. They're so excited. And then their ear just drains and drains and drains, and they're miserable, and you're miserable because you want it to close, you want the drainage to stop. And so, in places where nasopharyngeal carcinoma is endemic, like in Hong Kong, they've decided we will not place tubes in these patients. And so they just offer hearing aids because they think the quality of life is going to be better with a hearing aid rather than a tube. You've all probably seen folks like this in your clinic. And then you would be tempted to want to do balloon dilation procedures on these patients because that seems like a great solution for this chronic effusion. The challenge is that radiation has its effects over years to decades. And so at first they get this kind of intense inflammation, the muscles don't function as well, they're swelling. And so there's always this fluid there. But if they kind of get past that initial part, the tissues start to atrophy and shrink up, and then they're more likely to get patulous symptoms long term. There have been kind of at least in some small case series, a relatively high rate of patulus after balloon dilation of patients who've had radiation. And so I think the general recommendation, at least at one of the meetings that we had been to, was if you're going to do that, only balloon dilate for a minute to try to decrease the risk that they'll become patulous afterwards. The duration of balloon dilation seems to be related to the likelihood of developing patulous symptoms.
Very, very interesting. Thank you.
I think I heard another question.
Yeah, one more question, Dr. Ward. When you start with medical management for patulous eustachian tube dysfunction, and you don't see immediate relief, for example, if you do saline in the clinic, how long do you give a good medical management attempt, either with saline or hypertonic saline or something else, before you then discuss procedures?
Yeah, so I'll tell patients that that over half of patients don't need to get a procedure, and most are confident after some occasional medical management that they don't necessarily need to. If they don't get better with the normal saline solution, which is fairly common, then I will make sure that they try the hypertonic or the patulend. And they have to make sure that they get it to the right space. So I really want to hear them say that, like, yes, I felt the pain that kind of went up towards my ear, and then I walked around and it didn't make any difference at all. Or I felt it made a relief, but it only lasted for like 10 minutes. And then I just can't deal with this. My symptoms are, intolerable. They're really affecting my quality of life. At that point, that's when I'll offer something else. And I'll either offer that shim placement, or I'll offer mass loading of the eardrum by taking some steri strips, cutting them up, and kind of layering them bit by bit on the mobile parts of the eardrum. And I do that part in clinic.
Thanks, makes sense. Well, I think we've gone over it. That was awesome, very comprehensive, and really generated a great discussion. So thanks everyone for attending. And again, Dr. Ward, thanks so much for your generosity with time and a great presentation.
Yeah, my pleasure. Thanks so much for having me. This was a lot of fun. And thanks for involving me.
All right. Bye, everybody.
Ciao.
Thanks very much.
Bye.